But if we can help them sleep better, then we can help them feel better. And again, we can help them maybe respond to their other treatments better. And so that's something that's worth waking up for every morning.
Welcome to eShadowing Session 4 with the amazing Dr. Anita Shelgikar. How are you doing tonight?
Doing well. How are you doing?
I'm doing great. Thank you so much for taking some time out of your busy schedule away from your family to hang out with the thousands of students that are going to hang out with us tonight to share your specialty and everything that you do as a sleep medicine specialist. So thank you for, on behalf of all of the students watching.
Oh, my pleasure. Thank you for having me.
I want to start with kind of just in general what sleep medicine is and why neurology as a sleep medicine specialty.
Sure, great question. So sleep medicine is a multidisciplinary specialty. It's a fellowship program that follows a number of different specialties. And what we do is take care of patients across the lifespan who have sleep disorders. So difficulty falling asleep, difficulty staying asleep, sleep-related breathing disorders, sleep-related moving disorders, parasomnias, which are unusual behaviors during sleep, circadian sleep-wake disorders, circadian rhythm sleep-wake disorders. And so there's a lot that we can do to help people who are feeling excessively sleepy or can't sleep, and really with the goal to improve their quality of life. In terms of why neurology, so the way we measure sleep is through the EEG, the electroencephalogram. And so back when that was starting to be put into clinical use more often, neurologists noted that there were actually differences in stages of existence, wake, and different stages of sleep. And so that's how neurologists got involved in the study of sleep medicine. And it's evolved to become a very multidisciplinary field over the times, which is something that's the most exciting part of the field.
Now, there's usually a lot of humor around and jokes around how someone becomes interested in their specialty. Now, for someone to become interested in sleep medicine, you either really love sleep or you yourself had trouble sleeping. How did you become interested in sleep medicine?
So I'm definitely in the former camp. I love sleeping. And I don't do well if I'm deprived of sleep for very long. So I actually knew nothing about sleep medicine as a medical student and even as a junior neurology resident. It wasn't until I was a senior neurology resident and I was on the wards assigned with one of our sleep medicine neurology attendings. And we would all chuckle when we would make rounds because he would ask patients about their sleep. And we thought, well, this patient has an acute stroke. Why are you asking them about their sleep? Kind of eye roll, chuckle. And then what do you know? They had something to say about their sleep. And it was one of those things that once I started asking about it, it was everywhere. And it was kind of baffled me that I could have been that far into my neurology training and totally not have known this whole field of sleep medicine that really has the ability to help improve people's quality of life. So that's how I discovered it. I was, again, a fourth year neurology resident. So at that point, I decided to practice general neurology for a couple of years and, solidify my decision. And the more I asked people about their sleep, the more I was just fascinated by it. And so I ended up doing a fellowship.
Awesome. I want to ask about the training path to become a sleep medicine specialist. I know you have a presentation to give. Is that part of the presentation?
Sure. Yeah, absolutely.
Awesome. All right. Why don't we go ahead and get started with that then?
All right. So what is sleep medicine? It is a multidisciplinary specialty. It includes long-term patient management and occasional one-time consultations. So generally, we do develop longitudinal relationships with our patients. Oftentimes, we are doing chronic disease management for sleep disorders, disorders of sleep and alertness. And occasionally we will get one-time consultations, a patient who is being managed by their primary care provider or by another specialist who wants a one-time consultation about something in particular related to the patient's sleep. So we are trained to take care of patients of all ages at all phases of life. So everything from newborns to college-age students to pregnancy to adulthood and older adulthood. So it's really dynamic in that regard because we are seeing patients across the lifespan. our training encompasses both adult and pediatric sleep medicine. Oftentimes when people go into practice, they may choose to do adult sleep medicine or pediatric sleep medicine, but we are trained for both board certified for both, and some people do choose to see patients of all ages. So again, we see patients from all these different life phases, and it just keeps it really fascinating and engaging. So who can train in sleep medicine? Ryan, I think this was your question about how can you get into this field? Yeah. So following successful completion in one of these residencies, you are then eligible to become a sleep medicine fellow. So anesthesiology, family medicine, internal medicine, neurology, otolaryngology, pediatrics, and psychiatry. And I am a program director for our sleep medicine fellowship at the University of Michigan, and we consider candidates from all of these fields equally. It's not like we're looking just for one entry point or just for another. So it truly is a multidisciplinary field in its entirety. So how long is sleep medicine training? There's a 1-year clinical fellowship, and that is what is ACGME approved to be board eligible for the practice of sleep medicine. You can follow that clinical year with dedicated research training if you're interested. And there are a number of institutions around the country that hold dedicated academic time for training in sleep research in particular. So I'm going to give you an example of some of the clinical experiences that our fellows have at our program, which is similar to, I think, what a lot of programs do around the country, but I can speak best to what our fellows do at Michigan. So they rotate through a number of different clinics. So the assisted ventilation clinic is a partnership with the pulmonary medicine colleagues with whom we work. And in that clinic, patients often have neuromuscular disease, spinal cord injury, and then they have associated hypoventilation, sometimes sleep-related hypoventilation as well. So these patients are often on non-invasive ventilation and require longitudinal follow-up and multidisciplinary care. So in that clinic, they're getting ambulatory CO2 monitoring. They're having, again, multiple evaluations from different disciplines. And the reason our fellows spend some time in that clinic is to get a little bit more hands-on experience with non-invasive ventilation. We have a multidisciplinary insomnia group, and part of that encompasses cognitive behavioral therapy for insomnia group visits. So cognitive behavioral therapy for insomnia, also called CBTI, is the gold standard and most robustly evidence-based treatment for chronic insomnia in adults. And so these sessions can be delivered in group sessions or in individual sessions. So when our fellows start the fellowship, they may start in more of a shadowing role, and as the year progresses, they go on to lead some of the sessions in the CBTI groups. We have dental sleep medicine colleagues who are trained in the evaluation of potentially using oral appliance therapy for the treatment of obstructive sleep apnea. And when our fellows are with them, they get to see the dentist perspective of, anatomically, what are you looking for when you're considering if someone's a good candidate for oral appliance therapy or not? What kind of side effects for therapy are you monitoring as you're following patients longitudinally? Because if we do refer a patient to our sleep dental colleagues, we are co-managing that patient longitudinally. So it really helps as a sleep medicine physician to understand what our dental colleagues are doing when they're seeing the patients as well. Again, I talked about our multidisciplinary insomnia clinic. So in that clinic, our fellows will see a patient whose primary symptom is insomnia, and then they will staff with one of our sleep medicine physicians and also one of our behavioral sleep medicine colleagues who are psychologists who are trained in behavioral sleep medicine. So the goal of that multidisciplinary evaluation is to identify all of the contributors to a patient's insomnia and then develop a multi-pronged diagnostic and treatment plan to help that patient sleep better.
Let me ask you a question. So, and actually a student just asked this as I was thinking about it. And again, I don't know if you'll cover this in your slides, but in my mind, one of the questions that comes up is like, well, who cares, right? So the person can't sleep. What are the kind of systemic issues that come from lack of sleep?
Great question. So we consider it a disorder if it's disruptive to the patient's life, if it's either causing sleepiness, if it's disrupting the ability to function at the desired level, either occupationally, academically, interpersonally. It can cause hypertension, poor mood. Many Mood disorders are co-affected with insomnia, and so treating the mood disorder and treating the sleep together can lead to better patient outcomes. So it really has a multitude of effects on patients and their quality of life overall. So quality of life, functioning during the day, and again, medical comorbidity. So that's the so what. That's the why we care. That's a great question.
I'm never grumpy if I don't get enough sleep.
Well, then you should teach us, because I definitely can't say the same about most people that I know, including myself. Great question. Some of the other multidisciplinary experiences our fellows have, we have a multiple sclerosis and sleep clinic. So for those of you who have worked with patients who have multiple sclerosis, you know that fatigue is a huge component of the patient experience when they are living with multiple sclerosis. And so the idea in this combined clinic is to really pinpoint and do a deeper dive into the patient's fatigue and see, is there a coexisting sleep disorder? Because that would be treated completely differently from the management of multiple sclerosis. And if there is a suspicion for a comorbid sleep disorder, then we proceed with the evaluation and treatment as indicated. And again, the goal there is to help improve quality of life. This is a theme that keeps coming up for those of us in sleep medicine, is quality of life. And that's really something that resonates with me as a sleep doctor. And that's why I went into medicine in the first place. And being a sleep medicine physician really allows that on a day-to-day basis to help people sleep better and feel better. We have otolaryngology clinics, both adult and pediatric. So our otolaryngology colleagues help with upper airway surgery for the treatment of obstructive sleep apnea. So when our fellows rotate through those clinics, again, what they're doing is getting a better understanding of how our colleagues evaluate and treat patients, because again, we are co-managing these patients together. And so then they get a better idea of what are the indications for surgery, what are anatomical features to look for. They can shadow while the otolaryngologist is doing a nasal pharyngoscopy. And so they get a completely different perspective of the upper airway and for surgical treatment of sleep-related breathing disorders. It's the same case with our oral and maxillofacial surgery clinics as well, both adult and pediatric, understanding the surgeon's perspective in terms of indications for surgery, decision-making, counseling, and recovery, so that we are better informed when we're referring patients to our surgery colleagues. We have a pediatric refractory to CPAP clinic, and that clinic follows a tumor board model. So patients who are unable to use CPAP for whatever reason, and CPAP stands for continuous positive airway pressure. So that is the gold standard for treatment of obstructive sleep apnea in adults. In pediatric patients, we generally proceed with adenotonsillectomy first, but if there is persistent sleep apnea thereafter, then we do often prescribe CPAP. So for patients who are unable to use CPAP comfortably, we have this tumor board model clinic called the Pediatric Refractory to CPAP Clinic. And in that clinic, the patient will see sleep medicine, otolaryngology, dentistry, and oral maxillofacial surgery. They will have cone beam CT imaging of the upper airway and nasal pharyngoscopy. After the visits are all completed, the group convenes to review the sleep study results, the pharyngoscopy findings, and the imaging findings, and come up with a multi-pronged treatment plan to present to the patient, again, with the goal of treating their sleep-related breathing disorder so that they can have a better quality of life.
Can I ask you about a lot of students are asking about sleep apnea and kind of its effects. It seems like sleep apnea has exploded in the last decade or so in terms of just diagnosis and awareness. Is this something that we think has always been there and we're just kind of getting a better understanding of it, testing for it more with sleep studies? Or is this something potentially with our rise in obesity and potentially some other things that we're seeing more prevalence of sleep apnea?
Yeah, I think you hit on all very important points, and I think all of these contribute to the rising prevalence of obstructive sleep apnea. There's no question that among all medical providers, there is heightened awareness now of obstructive sleep apnea. There's more intentional screening done to identify patients who may be at risk for obstructive sleep apnea. And we have an aging population, and we have a population in which obesity is becoming more and more of an issue year by year. And so all of these things do contribute to the increased prevalence that we have seen over time. And to be honest, we think that it's still largely undiagnosed too, so that prevalence that's more recently cited is still probably an underestimation overall.
An interesting thought I just had, and I don't know if it's been studied at all, is we have a much more sedentary lifestyle as we continue on, and everyone's just on Instagram and TikTok all day long. And especially with COVID-19 and everyone quarantined, I having been an exercise physiologist major and personal trainer for a long time, obviously we know that exercise and being active increases muscular tone, just standing tone. Is there potential, and has it been studied, to where that decreased tone from lack of activity is causing some of that obstructive sleep apnea?
So that's a great question. So when we talk about impaired neuromuscular tone, we're specifically talking about the upper airway musculature, and absolutely impaired neuromuscular tone is a contributor to the pathogenesis of obstructive sleep apnea. So obesity is definitely a contributor, baseline craniofacial anatomy. So we definitely see patients who are at their goal BMI or even, underweight, who still have obstructive sleep apnea because of their craniofacial anatomy, impaired neuromuscular tone, and impaired arousal threshold. So there's much more sleep fragmentation, which can, at sleep onset, alters the apneic threshold. And so there can be this perpetual cycle of apneas and fragmentation during sleep. So absolutely, there are a number of contributors. Another thing is rostral fluid shifts. So fluid that may pool in the distal extremities while standing. That when a patient is recumbent, that distribution of the fluid to be more rostral and affecting collapsibility of the upper airway can also contribute to the pathogenesis of obstructive sleep apnea.
Cool. All right, keep going.
Great questions. And I was just going to add that, the university settings are places where you can train for sleep medicine, and VA medical centers also have training programs too. And in our veterans, we often see post-traumatic stress disorder and PTSD related nightmares, which again, when you think about quality of life and trying to contribute meaningfully to our patients, it's a huge thing for this patient population. And so again, being able to contribute in a meaningful way is really gratifying as well. A big part of what we do is polysomnography interpretation. So that's sleep study interpretation. So we see, again, patients who are, adult, who are pediatric, and the whole gamut across the lifespan. So a nocturnal polysomnogram is a baseline sleep study that's done in the sleep lab. Home sleep apnea testing is a specific cardiorespiratory test that is specifically designed to look for obstructive sleep apnea. It is best suited for patients in whom we have a moderate to high suspicion for moderate to severe obstructive sleep apnea, who don't have other comorbidities that would preclude them from having this type of more limited monitoring. A watch pat is a particular type of home sleep apnea test that has a little bit of a different mechanism for collecting data during the recording. CPAP, like we talked about, continuous positive airway pressure, and BPAP is bilevel positive airway pressure. So these are therapeutic modalities that we can test in the sleep lab to find the optimal pressure setting for a patient's sleep-related breathing disorder. We do studies with advanced positive airway pressure modalities as well. So VAPS is volume assured pressure support. So patients with hypoventilation may require this other type of modality to optimize their hypoventilation and sleep apnea if it's there as well. Servoventilation is a type of anticyclic treatment. So for patients with central sleep apnea with Cheyne-Stokes respirations, we will often use servoventilation if they are otherwise medically appropriate candidates for that type of therapy. Esophageal pressure manometry. An esophageal pressure manometer is something that looks kind of like a Dophoff tube. It's kind of a small bore flexible tube that gets inserted through the nares and swallowed down into the esophagus, which sounds fabulous. But what we're doing there is measuring intrathoracic pressure as a marker for respiratory effort. So that's not something that we do routinely, but we do have the capability of doing if the external belts to measure respiratory effort aren't giving us enough detail to confirm the clinical suspicion. Hypoglossal nerve stimulation is an FDA-approved treatment for obstructive sleep apnea when patients are not able to use CPAP therapy. And our facility does have the ability, our surgeons are trained to implant this device. So it gets implanted in the chest wall. It has a lead going down to the intercostal muscles, a lead going up to the hypoglossal nerve. When the patient activates this at bedtime, then it syncs with the patient's respiratory cycle, and at inspiration causes a stimulation to the hypoglossal nerve to open up the airway. So speaking to your question about impaired neuromuscular tone, this is getting at that etiology in the pathogenesis of obstructive sleep apnea. And then multiple sleep latency tests are a type of test that we do to quantify a patient's level of sleepiness during the day. So if we are concerned about a central disorder of hypersomnolence, then we may consider doing an overnight sleep study preceded by a couple of weeks of actigraphy, which is a wrist-worn device that's similar to the consumer sleep technologies that you've seen that estimate the amount of sleep on a given 24-hour period. So we'll do that, and then could do the multiple sleep latency test, which is a nap test, where the patient is given 5 opportunities to nap at different time points across the day. And we have normative data for how long it should take to fall asleep and what stages of sleep the brain should go into if sleep is achieved during those naps. And we compare the patient's results to those normative data. And there are diagnostic criteria for different disorders of central hypersomnolence. There are a couple other studies that we do as well. Yes.
While nobody wants any sort of disorder of any kind, the kind where the testing involves taking a nap is probably one of the good ones to have.
Well, I think the patients would probably say otherwise. These are patients who are excessively sleepy that, interferes with maybe occupational goals, academic goals. So yes, when you're sleep deprived, a nap sounds awesome. I think when you want to be awake and you feel compelled to sleep is when it's, when it's a problem.
How much, there's been a few questions around COVID-19 and potential effects. We've seen just every different specialty coming out with seeing neurological deficits, GI deficits. Have you seen anything in terms of sleep and how that's been affecting patients?
Absolutely. There is a growing body of literature about how sleep is affected by COVID-19 and by the pandemic. So, depending on the age of the study population, actually some mixed data, there's some data to show that school-age kids and even adolescents may be sleeping more, but may be shifted in terms of their timing, and that may be in sync with their biological clock at that stage of their growth and development compared to when they're going to school in person. And so there's some really interesting data there in the school-age population and in adolescents. For adults, there's a lot of data coming out about, heightened insomnia and sleep fragmentation in the setting of the pandemic as well, often attributed to anxiety, again, from multiple sources. But yes, so absolutely the pandemic has affected people's sleep. And anecdotally, when I'm seeing patients in clinic, even patients who I've been following for 5-10 years, have been coming in saying, I'm just not sleeping well right now. I've got too much on my mind. Yeah. So it definitely is an issue for sleep health.
Yeah. Okay, great.
Yeah, great questions. What are some sleep medicine career options? So you do your residency, you do a clinical sleep medicine fellowship, and then what? Lots of options available to you. So academic practice, you could be a clinician educator, a researcher, a clinical researcher. So lots of permutations there in the academic settings. In group practice, if you're working for a large hospital system and part of a multi-specialty group, some people may choose to do their primary specialty and sleep medicine. Some will do only sleep medicine. some of our graduates choose to go into solo practice. We have one of our fellows who just graduated in June 2020 who is working in a rural community, which is, really what he wanted to do. It's where he grew up. It's where he wanted to serve. And he is the only sleep medicine physician in a very large mile radius. And that's what he always aspired to do. And so he's serving his community in that way. So many different options. There are also opportunities for advocacy and public awareness because everybody needs to sleep. And so, it really is an opportunity for community outreach and community involvement as well. So if you're interested, I would encourage you to check out the website choosesleep, all one word, .org, which is hosted by the American Academy of Sleep Medicine. And there you'll find a lot of information, more information about careers in sleep medicine. We have medical student interest groups at a number of institutions. And if you're interested in starting one at your institution, that would be fabulous. And there's information there on how you can start a chapter at your school. There is some funding that comes from the American Academy of Sleep Medicine by doing so. It's also a great thing to put on your ARIS application as a leadership role to start a program from the ground up and plan the programming. So that's a great opportunity as well. There's a whole series of webinars which are fantastic that cover so many topics in sleep medicine, and they're free and they're posted on that site. So an easy resource to take advantage of. And if you then choose, to go beyond the choosesleep.org website and look at the Academy website at large, you'll see the clinical practice guidelines. You'll see a lot of other information that may be clinically relevant to the patients you're seeing right now as you're on your different rotations as well.
I love the eShadowing from last week, preventive medicine, this week, sleep medicine, two very, in the general scheme of things, very unsexy specialties that have huge impact on our population and on patients. And I love that, right? You'll never find a TV show all around sleep medicine because that's just not cool. It's not, you don't get the gunshots coming in, you have to save them and all that fun stuff like ER. So I'm excited to get more students exposed to sleep medicine because it's so important. Obviously, sleep such an important factor in our life. There was a question that came up earlier that I'm interested to know if we have any like real scientific data behind it, and I don't know if we do or not. But the question was like, from a physiological level, why do humans and I think all animals, there probably is one or two animals out there, why do we need sleep?
Great question. One of the holy grails, I would say, in our field. So it sounds like you are a budding sleep researcher, so yay. But yeah, there are a lot of restorative properties or processes that happen during sleep. Memory consolidation. We talked about adolescence. So there are some hormones that are, specifically associated with different stages of sleep. So for example, growth hormone is secreted during delta sleep or stage N3 sleep. There is more and more evidence that lack of sleep actually contributes to the pathogenesis of Alzheimer's dementia because it accentuates the buildup of plaques and tangles in the brain. And so again, a number of different restorative processes that happen during sleep and even in terms of our cardiometabolic health as well. So like you mentioned, it's not acute care. It is definitely longitudinal care, but all these sequelae from poor sleep, untreated sleep disorders, perpetual lack of sleep, all of these things do have an additive feel to them that after a while, all of these sequelae do increase risk for heart attack, for stroke, for poor quality of life, for mood disorders. And so there's really so many compelling reasons to make sure that someone can sleep well and obtains a sufficient quantity of sleep as well. So that's really what we strive to do, is to optimize people's quantity of sleep and their quality of sleep to help with the management of their other medical disorders if they exist, and also, again, to improve their overall quality of life.
Now, something specifically for this audience that is a very common thing are all-nighters cramming for a test. Give the elevator pitch on why students should not pull an all-nighter to cram for a test.
So fantastic question. And we've all been there, and we probably all felt like the next day was not our optimal day. There are data, again, looking at academic performance, test performance in particular, over the course of a semester. And as the amount of sleep decreases, so does the performance. As the amount of sleep increases, so does the performance. We are really horrible self-raters when we are sleep deprived. So we think we can function well when objectively we can't. And so sometimes it's hard to have that self-awareness when we are perpetually or chronically sleep deprived. But it does affect our reaction time, our psychomotor speed, our cognitive processing times. And so when you think about something like test performance, it really does not put us in a position to optimize our performance. You think about us in the clinical realm, where we are not taking a test, but maybe doing things that are really high sensitivity and high stakes in terms of patient health. Then we talk about increase of medical errors, decreased surgical proficiency, things that have very tangible outcomes from us being sleep deprived. So, at some point our sleep health is about us, but as we venture further in our trajectory as physicians in training and as physicians, our sleep deprivation then can affect the health of others who entrust us with their care. And so we even have a responsibility to them to make sure that we are optimizing our sleep so we can best serve them as well.
Great. And I don't know if you have this in your slides or not, but what does a typical day or typical week look like for you? And then as a woman in medicine, a lot of women coming up as pre-meds, as medical students, worry about work-life balance and family and all of that stuff. Can you talk about sleep medicine in terms of what that day or week looks like, and then what that work-life balance looks like for you specifically?
Absolutely. I'm so glad you asked both of those questions. Thank you. I feel like when I was a medical student, the question about work-life balance, or maybe not a medical student because I think I wasn't that self-aware, but certainly as I progressed in my training, these were questions I felt like I could never ask, but they were huge questions. So I'm really glad that you brought that up, Ryan. To answer the first question about what does a typical week look like, my week is kind of a split 50-50 between being in clinic and reading sleep studies. Since I'm at an academic medical center, my clinical time is sometimes me on my own. So I do have my own private clinics. Sometimes I'm reading sleep studies on my own, but sometimes I'm teaching the fellows. So they'll see the patients or they'll do the prelim read on the sleep studies, and then we staff together. And that's honestly the most fun part of my job, because I love that interaction. I love seeing a fellow start early July, kind of wide-eyed and brand new to the field. And then by the time they're graduating, they're teaching me all of these cool things that they've learned over the years. And so my time as an academic sleep medicine physician is split between private work and teaching work. And then I do have some other responsibilities that are related to the medical school and the curriculum there. So that's how I spend my time. In the private practice setting, I know my friends who are in private practice sleep medicine jobs, they have their time split as well between seeing patients in clinic and reading sleep studies. It kind of also depends on what their primary specialty is and if they choose to do that or not. So I have friends and colleagues who are, for example, pulmonary critical care doctors who are also board certified in sleep medicine. So they may have, X number of weeks over the year where they're rounding in the ICU or they're doing pulmonary consults. And during those times, they may cut back on their clinic a little bit, but still, see some of their clinic patients and still continue to read studies. Same with colleagues who are neurologists, psychiatrists. If they do any inpatient work, then, they kind of toggle those responsibilities accordingly. So it definitely gives room for flexibility depending on what your career goals are in terms of, do you want to do some of your primary specialty? Do you want to do only sleep medicine? One thing I should mention, that in the setting of the pandemic, sleep medicine is extremely amenable to telehealth. And so we turned on a dime in March, April, when we had the stay-at-home orders issued here, at least in the state of Michigan. And I think in most places around the country, when I talk to other program directors across the country, that we really switched the way we do things, and we were delivering care virtually, and we're still doing that to a large degree. So we are able to see patients, for those patients who are on PAP devices for treatment of sleep-related breathing disorders. All of their usage data from their devices are transmitted to a cloud. So we are able to access that, the PAP generated data on the cloud, and we were able to review that and look at their adherence, look at therapeutic benefit on paper, compare that with what they're saying. So it's been a really cool field that way, that we've been able to still meet our patients' needs. For patients, for example, who have excessive sleepiness, to not have to drive in now to come see us is actually a huge relief. And so it's given us a lot more flexibility and, the opportunity to be able to reach patients in areas that otherwise weren't accessible for sleep medicine services is really exciting. So that's something that we've been able to do as well. To the second question about work-life balance, yes, I am married. I have 3 kids and 2 cats. And the cats are older than the kids because they came first. And absolutely, my home life is just as important as my work life. You know how it is, like you work so hard to be a doctor and to train, and you don't want to let that go, but then you develop this other aspect of your life that just, like steals your heart. And it's really important to me to do both. And a career in sleep medicine does allow for that. It is largely an outpatient specialty. We do a very small handful of inpatient consults. And when we do inpatient consults, it's really primarily if the team thinks that the suspected sleep disorder is interfering with the patient's hospital stay to the point that it's either medically causing some worsening for the patient's status, or it's interfering with their ability to participate in therapy and get to rehab or things like that. So an example of some of the inpatients we may see, if a pregnant woman is admitted with preeclampsia and she snores and is hypertensive, then we may do a sleep study there. And if she's diagnosed with obstructive sleep apnea, start PAP therapy immediately with the goal of getting to term for the delivery. Another patient comes to mind who had congestive heart failure and was admitted for a CHF exacerbation, among other things, and was sleep so fragmented at night, separate from, procedural types of things and vital checks and whatnot, that during the day when the physical therapist, occupational therapist would come by, he'd be fast asleep. And so they're like, we think this gentleman can actually go to acute rehab, but we can't interact with him enough. So we were able to do a sleep study, get him on PAP therapy, and change the disposition of his hospital stay. So we do inpatient consultations when indicated like that, but it is 99% an outpatient specialty. So I would definitely say it's one that gives academic fulfillment, professional satisfaction in terms of being able to, again, help patients with their quality of life. And it is one that does allow for work-life balance as well.
Great. Let's keep going. What else you got?
So my next slide is just, I have a case after this, but I just wanted to put up my contact info, and our fellowship program can be found on Twitter and Instagram as well. And I'm on Twitter, and there's my email address. So feel free to reach out in any one of those ways. If you have more questions, I'd be more than happy to chat. And I have our website for our fellowship down there as well.
Nice. Thank you.
I do have a case if that would be interesting. You tell me.
Yeah, the students love cases. So let's do a case. I want to know, probably not the best data, probably because it's self-reported and survey data, but do we have an understanding of what percentage of the population actually gets good sleep?
Yeah, great question. Again, I think it depends on who you're asking and when you're asking it, but generally speaking, we are a sleep-deprived society, especially as our handheld devices, electronic devices, have made their way into our bedrooms, our living rooms, our everything, right? That they do chip away at our sleep as well. So on the whole, we don't get enough sleep. The recommendations for adults are to sleep at least 7 hours per night. Understanding, I should say, that the biological sleep need varies from one individual to the next. So it's not, 7 is not the be all end all for everybody, but that is the target for adults, is a minimum of 7 hours.
I got 6 hours and 50 minutes last night, according to my sleep app. Wearing my Apple
Watch. We'll
Watch.
let that slide.
Just like normal. I'm always coming in just a little bit short. Got that B+ instead of the A. All right, let's go ahead and get to the case.
All right, great. So here's a case from the sleep clinic. So this is a 56-year-old woman who presented to our clinic feeling that she was waking up tired, had headaches, and being sleepy throughout the day. So this is a woman who we first saw a few years ago, 5 years ago now, but because of changes in insurance status, she stopped coming to clinic and she now wanted to reestablish care in our clinic. So initially when she presented, she had a diagnosis of multiple sclerosis, presented with fatigue. And at another institution, years prior to that, she had been diagnosed with obstructive sleep apnea as well. And she had tried CPAP therapy, but ultimately found that it was too uncomfortable to use, and she stopped using it. So in the setting of her multiple sclerosis and fatigue, she tried a number of different medications to help her manage her fatigue. So methylphenidate, modafinil, both of these were tried, but she ultimately stopped using them because of side effects from the therapies.
Now, for the pre-meds watching this, those two medications, can you talk about what kind of medications they are? Are they to help the person sleep, or they help the person stay awake?
Yeah, thank you so much for asking that. So methylphenidate is an amphetamine-based stimulant. It is a controlled substance. It is tightly regulated by the FDA, and it is something to help with alertness. So this was something that had been prescribed to help manage her fatigue and sleepiness. Modafinil is classified as a stimulant as well, as a wake-promoting agent. It is not amphetamine-based. It's not exactly clear how it works, though it does seem to work on the dopamine transmitter as well. And so it is also classified as a controlled substance by the FDA. So these are medications that we use when people need help with their level of alertness during the day.
Okay.
Great question. Thank you. So again, when she had initially come in, she said she had been sleeping for at least 10 hours a night, but her sleep was not restful. So she was getting the quantity, but not the quality. So these are two things that we look for. She had a few awakenings during the night because of the urge to urinate at nighttime. She would snore a little bit, wake up with a dry mouth, occasionally felt that she was waking up gasping or choking for air. She never felt refreshed when she woke up in the morning. She would have a headache at least once per week, and she had difficulty with concentration. So back to the so what, this is a lot of what it is, getting time in bed but not feeling rested, having difficulty concentrating, and just overall not feeling well. She had been diagnosed with restless legs syndrome, so that's a sleep-related movement disorder that I'll talk about a little bit more in the coming slides. She was started on a medication called pramipexole, which is a dopamine agonist. If you look it up, you will see that it's also FDA approved for Parkinson's disease. Patients with restless leg syndrome, they don't have a higher likelihood of developing Parkinson's disease, but pramipexole acts on the dopamine receptor, and there is a role for dopamine in the pathogenesis of Parkinson's disease and restless leg syndrome. So that's why this medication is FDA approved for both. She would take the medication right before bed, and she felt that it would help her sometimes, but that she still had breakthrough symptoms on occasion. So in terms of her past medical history, she has bipolar disorder, had a nerve stimulator placed in 2006, obstructive sleep apnea, which, as we talked about, was untreated, hypothyroidism, asthma, and then her multiple sclerosis, like we mentioned. She is a lawyer, but was not able to work at that point because of her medical conditions. Ypsilanti is a neighboring town here in Michigan. It's adjacent to Ann Arbor. You can see medication allergies there. You can see here her family history, multiple family members with Parkinson's disease, several cousins with multiple sclerosis. Her medications, so Depakote, divalproic acid is something that's used for the bipolar disorder, Advair for asthma, Synthroid, which is for her hypothyroidism, and then at the time a cholesterol medication that she couldn't recall the name of, and nothing else that had come up on a full multiple organ system review. So when we saw her back again, she said, well, I'm actually doing well. She had gotten situated on CPAP, and then she had also been started on supplemental oxygen as well, and I'll talk you through that in a minute. And then she had said that her restless leg syndrome was well controlled with the pramipexole, but she noticed that the breakthrough symptoms, which before used to just be in her legs, were now moving up and including her arms as well. So this was a new thing that she had described. And she was recently started on supplemental iron about a month prior to coming in to see us. So her physical exam, I'm just going to summarize and say that her neurologic exam was normal. If you look at the HEENT, it says Mallampati class 3 oral airway. The Mallampati classification is one that comes from the anesthesiology literature. It describes the patency of the oral airway, classes 1, 2, 3, and 4, 1 being the most patent, 4 being the most crowded. And the Mallampati classification is meant to describe the likelihood of ease of intubation. It's one that the sleep medicine literature has adopted a long time ago, and so it is part of our routine clinical evaluation as well. So a class 3 oral airway is definitely on the more crowded side of an oral airway. Just something to note that we are obviously examining patients in clinic when they are wide awake and alert, which means that's best case scenario for patency of the oral airway, because when we sleep and our skeletal muscle relax, then the upper airway dilator muscles also relax. And so if we're seeing someone with a crowded oral airway when they're awake, then we can postulate that during sleep, that airway will become even more narrow.
And just for students looking at this and are like, what's HEENT? So head, eyes, ears, nose, and throat.
Thank you so much. That's absolutely right. Yes. Thank you for calling that out, Ryan.
That's all right. We'll learn these students up real quick.
So I just wanted to show you a little bit about what we do in the sleep lab. I would love to take you through an entire sleep study, but that will do a different webinar for that. This is something called the hypnogram. So this is kind of the visual summary of what we see on a sleep study. So if you see across the top, that is clock time. So you see it starts at 2300 hours, so 11 p.m. going to 6 a.m. Where it says REM, AWK, N1, N2, N3. Those are different stages of sleep. REM is rapid eye movement sleep, also known as dream sleep. Awake, N1, N2, N3 are all non-REM sleep, progressively going from lighter to deeper stages of sleep. It's color-coded here so that the gray straight line are periods of wakefulness. The green is N2 sleep, which is a type of non-REM sleep. And then there's really short slivers, I don't even know if you can see them, of like little periods of yellow, which is N1 sleep, which is basically drowsiness. And then those brown boxes are when the patient went into REM sleep, or rapid eye movement sleep. When we look below that, we can see a position summary. So you can see a green line, horizontal line, and then a blue horizontal line. That shows different sleeping positions that the patient is in over the course of the study. And then the vertical hash marks that you see in the next few rows going down are all showing respiratory disturbances that are scored during this study. So they're broken down into obstructive apneas, which is when there is cessation of airflow. So there's no flow of air moving through the upper airway, but there's persistent effort in the respiratory and abdominal musculature. A hypopnea, which is the row thereafter, is when the breathing becomes shallow enough to either cause the brain to have an awakening from sleep or cause the oxygen level to drop by at least 3%. And those can be either obstructive, so they can be associated with persistent respiratory effort, or those can be what we call central, which is when the effort also subsides and it's really reflective of the brain not fully generating a signal to breathe. Below that, we see central apneas, which is an apnea is when there's no flow moving through the upper airway. And a central apnea implies that there's also not persistent effort. So again, the reason there's no flow is because the brain's not generating a signal to breathe. We have some mixed apneas, which have features of obstructive and central apneas. This particular patient did not have any on the course of this study. The row below that, RERA, is RERA, respiratory effort-related arousal, which is another type of respiratory disturbance that we can see in the sleep lab. And then here you see the oxygen saturation. So this is going from 60 to 100. So generally you can see she's staying pretty good. When you see these really abrupt linear drops like this, that's usually an artifact in the sensor. You know, that's not physiologic to have that abrupt vertical drop like that. But you can see here, so if you move your eyes up to the stage of sleep, you see when she's in REM sleep that the oxygen tracing becomes much more erratic and the minimum level becomes lower. So this is something we see often in REM sleep, that sometimes the sleep-related breathing disorder becomes worse because generally speaking, our drive to breathe is lower in REM sleep. So you can see here that during this REM period and during this REM period, she has worsening of her oxygen saturations, and then they pick back up again when she's in non-REM sleep. These green hash marks here all show arousals. So that's when the brain comes out of sleep for a few seconds. Patient usually does not remember waking up, but we can see that fragmentation to the sleep. And generally speaking, her arousals are in sync with these respiratory events, all those respiratory arousals, because it's the breathing disturbance that's driving the arousal from sleep.
It's pretty crazy that we can get all of that data and know what it means. It's science is really cool in that way.
And I'll tell you what, Ryan, this is the tip of the iceberg. We collect 8 hours worth of data on patients in the sleep lab on a given night. And we are distilling it down to this information. But one of the most exciting things in our field is the potential to apply machine learning algorithms and artificial intelligence to signal processing and to scoring of our sleep study data. So I really think we've scratched the surface of what the polysomnogram can offer to us in terms of clinical yield. So definitely an exciting time to be in this field. For those of you out there who are interested in machine learning algorithms and neural networks and artificial intelligence, this is a fantastic field to be in because there is so much physiologic data that we are capturing in the lab. And then you think about consumer sleep technologies and all of the data that those devices are recording, and the sky's the limit in terms of what we could potentially offer our patients. So yes, I agree with you, Ryan. And this is one of the things that fascinated me. Started to get into it a little bit more, that what we think of as a quote unquote passive, clearly not. There's so much going on there. And then it kind of blows my mind to think that we're even capturing is really happening during sleep.
Is there a question that came up a long time ago, but I think is relevant right now, is the difference between a home sleep study and one at a sleep lab, is that a big enough variable that would change the results?
Yes, and so if we're going to be a purist, we won't call it a home sleep study because we're not actually measuring sleep. So we call them home sleep apnea tests. because they are limited cardiorespiratory tests. So for example, this study was done in the sleep lab. So all of these data about the stages of sleep, time spent awake, time spent asleep, none of that is captured on a home sleep apnea test because we are not doing sleep measurement during a home sleep apnea test. In a home sleep apnea test, we are looking for obstructive sleep apnea in particular. And so we are looking at flow, the airflow, so we can score these respiratory events. We're looking at respiratory effort, and we are looking at the heart rate and the oxygen level. And so it serves its purpose for the correct patient, but it is not a one-to-one substitute for an in-lab polysomnogram.
Great. Okay.
So this patient was diagnosed with severe central sleep apnea, actually, not obstructive sleep apnea. She had a titration study, which is when we bring patients into the lab, and this is a treatment study. So this is when we're looking at positive airway pressure. Usually we start with CPAP first, continuous positive airway pressure, and try different levels of pressure to see what best treats the patient's sleep apnea. So just long story short, the density of these hypopneas should be improving when we are administering treatment. So, compared to the initial study, we should not see it be this static in terms of the number of respiratory disturbances that persist. So for this particular patient, most of what was tested was not effective, but there was a brief period in which she was on CPAP of 5 centimeters of water and 2 liters per minute of supplemental oxygen, and that at least kept her airway open enough. It kept her oxygen level high enough, and that was prescribed as her treatment. And this is, I just wanted to show you an example of this. So I told you that we, in this era, we're able to access device-generated data that's stored in the cloud. And so this is an example of the kind of report that we can look at. So it's called a compliance report. We tend to usually refer it as adherence clinically, but on the device, it comes out as a compliance report. So you can see this is from a month's worth of data. So 24 out of 30 days, she used it overall 80% of the time. In that time, her usage above 4 hours was 60%, so 18 out of 30 days. When we look at her average usage on the days that she did use the device, it was 6 hours, 7 minutes. And so this is not measuring how long she was asleep, because the machine doesn't have the ability to measure sleep, but it's reporting how long was the device on. And so that's what this usage data is. This is the type of device that it is. It has the serial number here, and then what the pressure is set at. So like we mentioned, based on that sleep study, it was set at 5. EPR is expiratory pressure relief. So if you have continuous pressure coming in, sometimes it can be hard for patients to exhale against that pressure. And so the EPR, or expiratory pressure relief, kind of backs off a little bit when the patient's exhaling, so that it can be more comfortable to exhale against that constant stream of pressure. I should mention that EPR is a proprietary term. Different manufacturing devices call it by a different name, C-flex, A-flex. Generally speaking, we call it flexible pressure, but conceptually that's what it is. So there's a continuous delivery of pressure with CPAP, but at the beginning of exhalation, just to allow some comfort, the pressure backs off a little bit. In the therapy section here, you can see it measures leak. So the pressure is administered through a mask, and there is some leak that is by design. It's intentional, because if the power were to go out, we would want the patient to be able to exhale and breathe comfortably. So there is some component of that leak that is intentional. But there's unintentional leak. If the mask isn't fitting well, it can leak around the sides, it can leak into the eyes. And so that's the leak that we're measuring here. And 95% of the time, hers was less than 1 liter. Even if this was in the 20 to 30 range, I would be satisfied. So this is really good control of mask leak. If you remember, on her events per hour on the diagnostic study, it was well over 100. And now with therapy, it has come down to 1.2.
Wow.
That's fabulous. Yes. Our diagnostic criteria for adults are that an AHI, apnea hypopnea index, so the number of disturbances per hour of sleep. If it exceeds 5 and a couple other clinical stipulations, then we consider that to be the presence of sleep apnea. So to come from over 100 to 1.2 is phenomenal. And then this shows the breakdown of different types. We talked about central versus obstructive. And I mean, you're really slicing and dicing when the overall index is 1.2. But if that's higher, then seeing this breakdown gives us a little bit of an inclination as to what's going on and where we can intervene to, again, reach the goal. Cheyne-Stokes respirations are a type of central sleep apnea breathing pattern, and she did not have that on her study. So the usage data here is basically a graphic representation of the numeric data that we see here. And so sometimes that's just easier to go through when we're talking with patients, so that it's displayed in both ways, depending on what's easier to show the patient. But this is a really cool thing about the field as well, is that, we're talking to the patient and we can look at the data together and compare that with how they're feeling, what their experience is, and decide together, do we stay the course? Do we make any adjustments? And it's a really nice tool to have as part of that partnership that we have with our patients. Any questions about the data report here?
I don't think so.
Okay, great. Other data that we had from when she came in recently. So these are iron studies, iron level, or total iron binding capacity. Ferritin is a stored form of iron. And then the percent transparent saturation. So again, looking at iron stores. And so when you look at these off the cuff, they look pretty good. What I wanted to call your attention to is ferritin, which is the stored form of iron. The lab says that the normal reference range is like from 2 to 280. It's an extremely wide range. And so off the cuff, a value of 27, 28 is pretty normal. The reason I'm bringing this to your attention is because in the setting of restless leg syndrome, we actually would consider this value to be a deficiency, because our most recent guidelines and practice parameters say that we should be targeting a level of 75 in patients with restless leg syndrome. So that's why we check the iron studies when patients have restless leg syndrome. So what is that? So we talked about a sleep-related breathing disorder that this patient has, and we talked about how we've been treating it and how she's responding to that treatment. And then she has another sleep disorder, which is restless leg syndrome. So that's an unpleasant or uncomfortable sensation in the legs that is associated with an overwhelming urge to move the legs. And that's really the hallmark feature here, is this overwhelming urge to move. There is a circadian fluctuation, so it does worsen at night compared to during the day. And it can worsen even with prolonged sitting. So sometimes patients with restless leg syndrome will tell us, if I fly across the Atlantic, I am miserable. Or if I'm driving, I have to take frequent stops, just get out and walk around. So that can be kind of a test as well. Even that kind of is separate from the circadian fluctuation, from that day-night preponderance, worsening at nighttime, but that prolonged sitting as well. And the urge to move and the discomfort that goes with that urge to move relieves temporarily when the patient gets up to move or stretch or walk. But as soon as that movement and activity dissipates, then the discomfort returns. And this can cause difficulty falling asleep. It can be disruptive to staying asleep. So again, just like most things, this is a spectrum. For some people, it's very mild. For some people, it's extremely intrusive and disruptive to their quality of life. And so, on a case-by-case basis, we decide, how to proceed on the magnitude of their symptoms. So when the cause is unknown, we call that primary restless leg syndrome. It can be related to low brain dopamine levels in a particular region of the brain called the basal ganglia. And like I mentioned, low iron has been associated with restless leg syndrome, and particularly stores in the brain. And for those of you who like neuroanatomy, iron is a cofactor for the enzyme that's involved in dopamine production. So it's a cofactor for tyrosine hydroxylase. So that may be how these two things are connected as well. There are a lot of genes associated with this, so I just wanted to put this up. I'm not going to go through all these genetic loci with you, but just to show you that, again, the more you dig, the more you find, and there are a number of genes that have been identified, and some of these do co-localize with iron metabolism genes as well, so giving more credence to the hypothesis that iron metabolism is related to the pathogenesis of restless leg syndrome. And it can accompany a number of conditions. So conditions in which iron deficiency can be a hallmark feature. End-stage renal disease and hemodialysis, for example. Iron deficiency for a number of other causes. Maybe it's due to low intestinal absorption or loss because of chronic bleeding. Pregnancy, especially in the last trimester, that can be associated with lower iron stores, so that can worsen as well. When women are pregnant, they will say that after delivery, oftentimes their restless leg syndrome does get better. There are certain medications, so antihistamines, dopamine antagonists, which are often used to treat psychiatric comorbidities, serotonin, norepinephrine reuptake inhibitors, selective serotonin reuptake inhibitors. These things can worsen restless leg syndrome. So this is, again, where we have to have a partnership with the patient and with the other providers who are helping in the patient's care. Because if someone has, really debilitating depression and is stabilized on a medication regimen that includes an SSRI, for example, we're not going to just focus on optimizing the restless legs at the expense of their mental health. And so that's where this discussion with the patient, with the other teams who are involved in the care of the patient to say, okay, big picture, what are our goals and what are we trying to achieve and where can we achieve some sort of balance that at least, mitigates symptoms enough for the patient to feel like they can function well and sleep. Alcohol, nicotine, caffeine, all exacerbate restless syndrome. Have neuropathy, so they have nerve damage in the distal legs that can cause a worsening of restless leg syndrome or a higher incidence of restless leg syndrome. And sleep deprivation and other sleep disorders like obstructive sleep apnea can worsen restless leg syndrome as well. So it's one of these things that, I never knew about before I started studying sleep medicine. And again, it's one of those things that once you start asking, it's everywhere. And so this really is, something that can disrupt people's sleep and their sleep quality, and it gives us an opportunity to help. So our plan with this patient was to continue with her CPAP of 5 centimeters of water based on her clinical response and based on the response on her data download. At this point, she's been on CPAP for a while, and from what we could tell through her chart review and through her history, it seems like her lung function has been stable. And so our plan was to do what we call an overnight oximetry, so have her be at home using her CPAP, but not the oxygen, and do overnight oxygen monitoring to see, does her oxygen level stay up with the CPAP alone? Because in that case, then there's one therapy that we can discontinue. It's one less thing she has to pay for. Oxygen in particular can kind of tether people, either they have to have the concentrator in their home environment or they have to take tanks with them when they travel. So being able to discontinue that one part of therapy and continue with the CPAP can be, a huge change for people. We decided, based on her iron stores and given her clinical history of restless leg syndrome, that we would continue the iron supplements for 3 months, and then we'll plan to check her blood work again in 3 months' time to see, has her iron level bumped up or not. With that iron supplementation, does her restless leg syndrome feel better now? Sometimes if people don't respond to oral iron, then if they are appropriate for iron infusion, then we will proceed with that as well. And we do that on a case-by-case basis. And there's some other labs we have to look at as well. And then the reason I'm putting up this last thing, consider changing from pramipexole to another medication. So if you remember when we were talking about her clinical history, she said that initially she had this restless leg syndrome, but that in recent months, it seemed to be kind of crawling up her body. So not only was it affecting her legs now, but also affecting her arms. And that's something that we call augmentation. And that has been described particularly with the class of drugs that are known as dopamine agonists, which pramipexole is one. And so these are data that have come out as these medications have been in use longer. So earlier clinical practice guidelines and practice parameters do call them out as first-line treatments. A lot of the more newer recommendations are saying, maybe these should be second line now, because this side effect of augmentation can be really debilitating for patients depending on how severe it gets. And so we talk to the patient about, okay, well, you're describing symptoms that are consistent with augmentation, you're on this medication. What are your thoughts about trying to either stay on this medication and watch how things go, or do you want to transition? And where we settled on was she thought big picture that the medication was doing her more good than harm. So she felt like she was getting more relief than she would to not be on it. So she did not want to change medications at that time. So we thought we would focus on the iron supplementation, because there are data showing that when the iron stores are low and not at goal, then augmentation gets worse. So we thought, okay, this would be kind of in line with the patient's preferences to continue with the medications, and we can try to optimize this other factor of her iron and see how things go. And we'll have to follow clinically, does this augmentation get worse? And if so, then, revisit the discussion of weighing the risks and benefits of the medication to see at what point do we consider a move and a transition to a different type of medicine. So that was my case. I thought I highlighted a couple different categories of sleep disorders for you. So a sleep-related breathing disorder and a sleep-related movement disorder as well, coexisting along with other medical and psychiatric conditions. So, these are the patients who we see. There's a lot going on that influences their quality of life, but if we can help them sleep better, then we can help them feel better. And again, we can help them maybe respond to their other treatments better. And so that's something that's worth waking up for every morning. So again, I have my contact info here, same with our fellowship program. You can find them on social media as well. And I'm happy to take other questions if you have any.
Oh, that was awesome. Thank you so much for that. I think the most interesting thing for me is that when a student thinks about sleep medicine or hears about sleep medicine, they probably don't think about how technical it can get, and how many different tests and just how many different studies you can do, and the different places that things can be happening. And so I think hopefully it opens up students' eyes to what's there and how interesting it all can be when it all comes together.
Yes, absolutely. And I would, implore you to think about your own sleep and your own sleep health. And, I hope that you go on to be sleep medicine specialists. And even if you don't, still ask your patients about their sleep, whether you become a surgeon or an internist or a pediatrician or an obstetrician gynecologist or any other. There's so many wonderful specialties out there. But everybody needs to sleep, and everybody needs quality sleep, and they need the proper quantity of sleep. So it really does affect every organ system. And it really is something to have on our radar when we're trying to optimize health for our patients. So ask about sleep, and if it's an issue, then feel free to refer them to a sleep medicine specialist.
Well, Dr. Shelgikar, thank you so much for coming on and sharing your wisdom, sharing your time with everyone today. I appreciate it, and hopefully we'll have some future sleep specialists here in the audience with us today.
That would be awesome. Thank you so much for the invitation. I had a great time.